Amruta, you start now. You
Yes,
welcome
sir.
President sir. Now.
Yes, sir. Yes, sir. A very good evening to all the respected dignitaries, faculty, delegates who have joined here today over the Maha-IIP platform. I'm Dr. Amruta Shirodkar, and on behalf of Maha-IIP, I welcome you all to another episode of Top Academics. TOP, which stands for Tips of Office Practice. We know it's a hugely successful online program running over the Maha-IIP platform. Before we begin the program, I would like to welcome our Maha-IIP President, Dr. Ram Gopal Chejara, sir, and I would request Dr. Ram, sir, to please say a few words.
Thank you, Amruta. Good evening, everyone, and welcome to another episode of Talk, that is Tips of Office Pediatric Practice. Here, the name itself suggests that our faculties would be giving tips in handling the cases or day-to-day cases which we are coming across. So for today's session, we have two topics. One is failure to thrive in under 5 children. And for that, we have an expert, Dr. Balwant Khobragade from Nagpur. And second topic is mastering childhood infection in solo practice. And for that, we are having expert Dr. Pramod Kulkarni, sir. He is EB member from Pune. So welcome, sir. Without taking much time, I hand over to Amruta so that we can start the session.
Thank you, Dr. Ram, sir. I would now like to invite today's moderator for the session. Today's moderator is Dr. Sanjeev Joshi, sir. I welcome you, sir. Sir is a Central IIP EB member from Yavatmal. And sir will be moderating this very interesting session today. Over to you now, sir.
Respected President of the Maharashtra IIP, Dr. Ram Gopal, today's esteemed faculties, my beloved teacher, Dr. Balwant Khobragade sir from Nagpur, and my senior colleague and dear friend and mentor, Dr. Pramod Kulkarni from Pune. I welcome all these esteemed faculties for this month's top activity of Maharashtra IIP. Thank you, Amruta, for accepting our invite on the last moment. And a grand welcome to all the Maharashtra IIP honorable members who have joined on this virtual platform. Since our president has already told you that the name itself is Tips in Office Practice. And friends, today's topics are immensely important for office practice in the pediatrics. One is the topic related with the faltering of the growth, and another is the infection. We all know that we are growing sciences. All the other fraternities, they are not growing, but we are growing. And so whatever issues of the growth and development are concerned in our day-to-day practice, they have to be evaluated in our routine clinical practice. So assessment of growth is one of the important aspect of clinical examination in our office practice.
Am I audible?
Yes, sir, you are audible.
Okay,
so let me finish. Today's first topic is the failure to thrive under 5, and our faculty is none other than one of our most popular and beloved teacher, Dr. Balwant Khobragade, who happens to be the ex-professor of pediatric, MUHS, and also the Savangi Deemed University. He was lecturer in our times, very popular amongst our contemporaries, one of the voracious reader and he has a keen interest in the field of intensive care. His work
अभी
in
आवाज आ
sickle
रहा
cell
है
anemia is well acclaimed. He has a lot of publications and
उसको ये लगा
awards
तो क्या
to his credits. So with this
हाँ
brief introduction, I hand over I request Dr. Khobrakade sir to share his screen and start his deliberation on a very common topic, which is failure to thrive below below 5 years. We know that assessment of growth can lead to so many clues in the diagnosis. If at all you are dealing with some condition like acute or chronic, and if you see that there is a lot of faltering of the growth in that particular child, that gives you a lot of clues to the etiology. So over to you, Dr. Khobragade, sir.
good evening to everybody. Am I audible
Yes.
and my
Yes, sir.
screen is visible?
No, sir. Your screen is not visible.
So how to make it?
Sir, there is a share the screen is there at the
Share this.
bottom.
Right.
You just click that and select your presentation.
Share the screen.
Yeah.
हाँ ये share है.
हाँ.
Green color
Click
button is there,
that.
sir.
Yes,
Green
हाँ,
color
ये-
button. Click that, sir.
इसको राइट क्लिक करना पड़ेगा.
नहीं नहीं एक क्लिक करो सर आप.
आया क्या? हाँ
आ गया सर. अभी
Right.
इसको फुल स्क्रीन कर लो. आप फुल स्क्रीन कर लो.
राइट.
इसको फुल स्क्रीन कर लो सर. प्रेजेंटेशन मोड में लेके आओ.
Is it all right?
Yes, sir. It is okay.
Right.
You can start.
Right. Good evening to every one of you. Dr. Joshi, the coordinator and chief executive for the today's webinar on a very common topic, that is failure to thrive. We all know that every now and then we have got patients where the mother complains that my child is not eating, he is not doing well, he is not growing well, and that is the most common presentation with which the child comes to us. Now today I am going to discuss about what is this failure to thrive, why we get failure to thrive, how to classify, and how to evaluate and manage these patients. Now, as we know, in the simplest term, failure to thrive is nothing but when the weight for age, weight for height, length, or height for age, the BMI, that is body mass index, and weight velocity, all these growth 5 parameters, when they are below 5th percentile, or when the Z score is less than -2, that means -2.5, -3 like that, or -2 also, then this particular entity is referred to as failure to thrive. Now, this failure to thrive also is applicable to sex appropriate and ethnicity appropriate growth charts. Unless they are followed, we may not be able to define a particular child whether he is having a failure to thrive or not. And why do we get this thing? This is because of the inadequate intake, use, or disposal of calories. That means the food which the child is taking either is inadequate, or it is not utilized properly, or they are not disposed of properly, and this is because of the various biological, environmental, or psychosocial factors prevalent in the society. So this is what is failure to thrive. Now, in addition, if you follow this particular child over a period of time, you find that his growth velocity also is slowing down by 2 major growth percentiles, as it is being shown over here in this particular graph. Then this particular child is also said to have a failure to thrive. So not only cross-sectional, but more often the longitudinal or follow-up progress of the child will tell us whether he really has got a failure to thrive or not. Now, does it really mean that all these patients are failure to thrive or not? Because single observations may not tell us the reality of the situation, and therefore we have to observe this child over a period of time. So the importance of growth charts. Growth charts are immensely useful in this evaluation of these particular children. Usually it is common below 3 to 5 years of age, And small size alone does not mean that the child has got failure to thrive, because it could be constitutionally light child, or there could be a transient weight loss which is associated with acute illness. So we have to differentiate a true failure to thrive from the one which is not associated with failure to thrive. Now, why we are concerned about the growth of the child? Normal growth, what does it mean? It means that it is an indication, a bona fide evidence of normal internal and external milieu of the child. That means he is all right if the growth is normal, and therefore it has got its importance. Not only for the child, it is also important, a bread and butter for the pediatrician. Failure to thrive is the most common symptom seen in the office practice, as low as 5% in Western countries to as high as 20 or 25% of the OPD patients in our population. And there are plethora of conditions responsible for that. However, it is all preventable and treatable in majority. And the investigations and clinical appraisal or has to be done. And if it is done properly, focused clinical lab approach will give a proper diagnosis. If untreated, however, and if missed because of the heavy rush in the OPDs, these patients can land up with persistent nutritional, physical, and psychosocial and cognitive development lag. And therefore, the importance of early diagnosis and proper treatment. Now, let us come to the growth characteristics. Now, we have got a various patterns of growth. One is called as ICA model, that means infant, child, and adolescent model. What is the importance of this ICA model? The ICA model tells us that the growth is very fast during fetal and infancy. For example, as this sigmoid curve tells us that in the first 2 years of life, the growth is very fast. At the same time, the brain growth is very fast in the first 2 to 5 years of age, right from the fetal life. And therefore, this is a crucial period for diagnosis and management of the children. Now, then after say 3 to 5 years of age or after 2 years of age, you find that the general growth of the child, it slows down. And therefore, most of the children, they are brought at this age by the mother that my child is not eating well and he is not growing well as compared to the previous years. Then similarly, the growth could be neural, general, lymphoid, and reproductive. And as we know that in first 2 years of life, the general and the neural growth is very fast and is very important. At the same time, there is a critical time and phase in the growth of the child. If during that time, the appropriate opportunities and the food is not being given to the child's development could be retarded for a sustained period of time. The variety of controlling factors, as we know, could be genetic, familial, or environmental. Now, this curve also tells us is a velocity curve, which shows that there is a slump, there is a rapid downhill course of the velocity of the growth by the 2 years of age. And this is the time when most of the children, they are brought with the history that my child is not growing well. And if we tell them with this graphical presentation that this is the normal growth phase where the growth is slow and therefore you need not bother about. Now, coming to the fetal stage of development. Fetal stage is classified as fetal growth restriction, and it is estimated by fetal weight or abdominal circumference assessed by the ultrasound. And if it is less than 10 percentile, then it is called as fetal growth restriction. Similarly, another term, what is called as a small for gestational age, is a term it is applied when the child is born. And if his birth weight is less than 10 percentile, then this particular child is referred to as small for gestational age. Now, coming to the fetal stages, the first trimester, second and third trimester. In the first trimester, it is mainly the genetic endowment of the child which is responsible for controlling the growth of the child. Plus, maybe that the genetic endowment is modified or curtailed down by some teratogenic factors or the first trimester transplacental infection. Later on, the growth is essentially dependent upon intrauterine environment, also modified by demographic and socio-cultural factors. So these are the very high risk factors which decide the growth of the child, which impede the growth of the child. And these are four, mainly illiteracy, and side by side along with that, the poverty, the birth weight, and the lactational failure. These are the ones which are responsible for the infantile growth phase in a particular child. Now, this particular slide will tell you how the psychosocial phenomena which definitely interferes with the normal growth of the child. Here is the mother-in-law with her own child in her lap. Here is the daughter-in-law with her premature and IOGR babies being born very soon. And you see that the childhood marriages, they are responsible for such phenomena. And such babies, when they are growing up, they will be definitely retarded if they are not being properly taken care of. So this is one slide tells you a lot of things which is occurring in the environment, in the society. Now, in the later life, infancy and childhood, there is the interplay of the genetic and environment factors. Moreover, the environment factors, and they are non-organic. That means the organ system is not significantly affected, but it is the environment which is influencing, and it could be occurring in the preconception phase, prenatal phase. There could be marital disharmony, domestic violence, maternal deprivation, and faulty child rearing practices and feeding techniques which is not proper, and economic stress. So these are the non-organic factors. This will elaborate later on. Now the organic factors also, there could be a system which is being affected, various systems like gastrointestinal, the respiratory, the cardiovascular, the renal, endocrine, so on. And if these are abnormal, then in this case, the child will have a defective growth. Naturally, it is not there is a hard and fast barrier in between, and there could be some overlapping phenomena, and therefore giving rise to mixed causes for the growth retardation. Now coming to the etiology of infancy and childhood, find that the higher risk factors in infancy and childhood, what are they? They are again illiteracy, poverty, then the familial and genetic factors, growth profile of the family itself. The family parents themselves may be retarded, they may be underweight, and height is also low, and therefore their kids also may be accordingly low in growth profile. Culture and customs, taboos, disharmony, domestic violence, familiar feeding, trends, attitude, atmosphere, peer pressure, illness, they all influence the growth of the child. Similarly, certain unavoidable factors like single parent, nuclear family, working mothers, they also give rise to a lot of difficulty in rearing of the child. Screen time. Nowadays, there is a lot of screen time being devoted by the child, and advertisement of junk foods and low fiber diet, that gives rise to the development of growth retardation. Similarly, recurrent and chronic infection, either because of water, sanitation, and hygiene being inadequate, giving rise to recurrent chronic infections, particularly GIT infections, and a lack of immunizations. Most of the times we find that many of the kids, they are not being properly immunized. Now coming to the nutrition part itself, why the inadequate intake occurs? The nutritional deficiency, either because of poverty, ignorance, the failure of lactation, breastfeeding. The vegetarians, mainly the vegetarian type of food, is deficient in some of the proteins, and then the certain micronutrients like vitamin B12, the food allergies, food fat, low fiber diet, the child neglect, abuse, mechanical problems, systemic disease, and prenatal insult. They all are responsible for the inadequate intake of the nutrient, and this is called a nutrient dependent growth failure. The calorie wasting, whatever the child is taking, it's all lost either by vomiting or by diarrhea in conditions like chronic conditions like cystic fibrosis, celiac disease, and rare conditions like renal tubular acidosis, osteodystrophy, diabetes, and inborn errors of metabolism. So this is another cause. Then there are another two more important reasons why we get the failure to thrive. One is congenital heart disease, respiratory disorders like the uncontrolled asthma, cystic fibrosis, again, recurrent infections like tuberculosis, HIV infections, recurrent pneumonias, hyperthyroidism, and neoplasms. And last but not the least, the altered growth potential, either because of a remarkable insult to the growth during the prenatal period, chromosomal abnormality, and endocrinopathies. Clinical features, how to diagnose them? By anthropometric methods, early fetal, late fetal, you find that head circumference is maximally affected, of course, along with the weight and the length. But while in infancy and childhood, head circumference is a sparing effect, and more often the weight is affected. And these are the methods, anthropometric methods of scoring. Z score is a very useful method for the correlation between the weight, height, and head circumference parameters. Z score is calculated by the deducting the population mean from the present weight of the child and dividing it by standard deviation, whatever it comes, that gives us the Z score. Now the growth velocity is also slowed down on follow-up in this patient. Psychosocial development domains becomes retarded. They have got irritability, excessive crying, lethargy, unresponsiveness, constipation, infrequent urination in infants is also important. Bedwetting may be there. Then clinical features of systemic disorders may be there depending on system involved, and signs and symptoms of associated vitamin, nutrition deficiency and infection may be there. This is one slide which shows a patient of Kwashiorkor with vitamin B12 deficiency where he has got a full-blown picture. Now approach to a child with failure to thrive. Classification and etiological diagnosis. If the child has got a normal head circumference but weight is significantly affected than the height, then it is a recent energy deprivation, and this is because of the deficient intake or malabsorption. If it is a normal or increased head circumference but weight is modified or reduced in proportion to height, then it is a constitutional dwarfism, endocrinopathies and structural dystrophy. Subnormal head circumference is there, but weight is decreased in proportion to the height, then in that case it is primarily the neurological disorder or a severe IUGR and insult during the intrauterine life, which is either because of genetic or chromosomal disorders. Now, pattern 1, there is inadequate intake, and this leads to feeding difficulty at fault, poverty and ignorance, and disturb infant-mother relationship. The weight gain is satisfactory after supervised feeding. That is the pattern 1 type of malnutrition or failure to thrive. Pattern 2 is inadequate intake, but there is a malabsorption also. There is a excess loss. Weight gain is not satisfactory even after supervised feeding. And these are the examples. Suppose there is a malabsorption syndrome of a patient of HIV infection who had failure to thrive, weight loss and diarrhea. Another patient of abdominal tuberculosis having failure to thrive. The pattern 3 where you get inadequate intake, but there is no weight gain at all. And these are because of the difficulty in sucking, swallowing, mechanical or primary neurological disorders. They have got inability to take large quantities like chronic infection, cardiopulmonary diseases, and vomiting is present in certain diseases, maybe GIT or metabolic conditions. And these are the examples. Here is a patient of cleft palate, the bilateral cleft lip, showing a gross inability to take the feed. Such patients, unless they are being properly taken care of, likely to land up with a failure to thrive. Similarly, a child with palatopharyngeal incompetence, a child with a gastrostomy tube, and a child with multiple problems born with a prematurity, IUGR, multiple congenital anomalies, the generalized floppiness, and congenital heart disease, failure to thrive. These are some of the examples of the category 3. Now, history. How history will be helpful? Either you take prenatal history, natal and perinatal history. All these histories are of immense importance in assessing or evaluating a child with failure to thrive. Now, postnatally, you have to find out the growth and again charting on the growth chart, immunization, illnesses. Social history is equally important. Loss of a job, divorce, death in a family, social and economic support. And recently we had a lot many cases of post-corona cases where the one of the members of the family being died, and therefore the family was in a financial constraint and therefore had a problem with rearing up the child. Same thing is about dietary history. Very important about the breastfeeding. There should not be failure of lactation. The weaning process, the food likes, dislikes, difficulties and allergies, food taboos and misbeliefs, all this should be evaluated on history. Then history of anorexia, vomiting, regurgitation, this will tell that there is certain organ system involvement, and recurrent fever expression will also tell us about the system's involvement and recurrent aspirations. Now coming to the specific behavioral pattern which is seen on physical examination, we find that there is a decreased vocalization. Child is aloof, child doesn't want to communicate. There is a lack of cuddliness. There's a sometimes maybe behavior problem like thumb sucking, rumination, tantrums, head banging and rocking movements. Social attitudes and peer group activities, they are also limited in these patients who have particularly toddlers and children just along 4 or 5 years of age. Features of child neglect or abuse may be seen. That is because of unwashed skin, diaper rash, untreated impetigo, uncut fingernails, flattened occiput, and alopecia over the occiput region, torn frenulum. All this indicates the child is neglected all throughout, and therefore he has got such type of clinical signs. Evaluating the child, use of appropriate growth charts, I have highlighted several times. Developmental assessment found out whether neurological is equally affected. Parent-child bonding and interaction has to be seen. Assessment and observation of the feeding, particularly type of feeding, frequency, amount, food refusal, slow feeding, gesturing during feeding, all this has to be evaluated. Normal variant has to be differentiated, Ex-premature infant, they may have a slow progress and then ultimately may catch up. The constitutional, they may have a low birth weight or their birth weight may be normal. They progress along the percentiles, which is initially there is a fall and then they pick up the percentiles, and parental percentiles are normal in these cases ultimately. Infantile anorexia nervosa is another condition where child has got a lack of the feeding attitude, and this is more often a behavioral problem because of the conflict of autonomy between the child and the mother. And then another genetic short stature is another condition where you find that ultimately the percentile will be low in this patient. Cash down growth occurs particularly in certain exclusively breastfed babies, where you find that the birth weight is above expected, but they cash down, and ultimately, if they are being not taken care of, they persist to have a failure to thrive. Lab investigation is limited to only those who have got a symptom suggestive of system involved. Otherwise, they are not to be done. Only the clinical evaluation is more important than the lab evaluation. These are the ones which are required in, then when there is uh, system involvement science present. Now, if the patient has got a given a diet chart and you find that there is a good intake or a poor intake, we have to find out after a 2 weeks evaluation. Then if there is a good intake but there is a poor response, abnormal stool will tell us that there is a GI problem. If there is a normal stool, it will indicate that there is a poor utilization or there is thyrotoxicosis. If there is a good response, then that will indicate that there was a caloric insufficiency. It was mainly because of the parents' neglect that the child was not given appropriate feeds. Now here there is a poor intake and feeds well but regurgitates, again indicate the GR or RT or chronic renal failure or neurological problems. But if he has got a sucking swallowing problem, as I have shown in the slides, then he has got a neuromuscular disorder. If there is a decreased oral intake, indicates that there is a feeding problem, either because of the systems involved, infection like tuberculosis or other system, and CVS, RS or hypothyroidism. Now management goals. How to manage this child? Early diagnosis is the most important thing so as to prevent the long-term morbidities. Counseling about cause, course, progress and future has to be told to the parents and the mother particularly. Their expectations are very high when they come to the pediatrician, but the reality of growth prospects has to be told to them, explained to them, counseled to them very vividly that if you yourself are not having a good growth potential, then this child may not be benefited very much. They only go on asking for tonics, but that does not serve the purpose. Promotion of adequate and balanced diet during any ANC is very important so that the baby who is going to be born does not manifest any signs of the dysmaturity or immaturity or the small for gestational age. Then breastfeeding, weaning, homemade calorie dense diet has to be done. One word about the breastfeeding. Many times the breastfeeding to be successful should start from the labor room itself or the OT itself, and the adequate care should be taken that the child is being given a proper feeding. Role of food supplements and the iron, zinc, vitamin D has to be there. Nutritional education and rehabilitation, achieve weight for height, first and treat organic cause, find and treat organic cause if it is any, and address psychosocial and developmental issues along with these are the goals. Now, during pregnancy, one has to see that the prospective mother must get adequate calories, proteins, vitamins, and they should have additional, say, 450 calories and the proteins around 15 grams in addition to what they were taking. And there should be good weight gain of the mother during the full pregnancy to the tune of, say, almost 12 to 15 kg over a period of, say, 9 months. Now, feeding during infancy. Educate, prepare mother during ANC for breastfeeding. Start earliest possible time after delivery. Exclusive breastfeeding till 6 months and to continue subsequently. Encourage kangaroo care, which promotes the breastfeeding. Schedule for preterm and demand feeding for full-term baby has to be applied, has to be used. No pre-lactal feeds to be given. Encourage baby-friendly hospital practices in each and every case of the baby, and monitor the growth of the baby during exclusive breastfeeding. Sometimes what happens, the breastfeeding may not be adequate and baby may develop some complication. Weaning. Now, what type of foods to be given? It should be energy rich, It should be palatable in a child to be started by 4 to 6 months of age, easy to chew, masticate as well as swallow, easy to digest and semi-solid in nature, low in bulk and low in viscosity so that the child do not develop any choking while taking the food. And it should be fresh as well as home-based. Cereals, tubers, legumes, oil seeds and oils and fats, vegetables, fleshy fruit, sugar, jaggery has to be used. Milk and meat products and non-vegetarian if possible should be used. Family pot feeding is very useful for nurturing the taste and saves time and money. These are the various calorie intake, 100 calories from this much amount of the milk, rice, chapati, vegetables and egg boiled. This I have cataloged here. And these are the energy dense foods, the porridge, the rice, the kanjis. These are all the energy dense foods which are called as which are from cereals, wheat, maize. Building block foods like dal, nuts, beans and eggs and milk, and protective foods like dark green leafy vegetables, fruits and carrots, and digestible food in the form of malting, fermentation of grains and cereals. This is how the variety of foods has to be included so that a balanced diet is being given. Guidelines
So
for
last
initiation.
minute.
Yes, just I'm about to finish. Start by 4 to 6 months plus breastfeeding. Introduce single nutrient food at a time. Mashed tasty semi-solid is to be given by 4 to 9 months. Chopped pounded food is to be given by 9 to 18 months. Freshly cooked warm food, not too hot and or cold. Food and kitchen hygiene to be adopted. Variation in taste, like dislikes to be ignored. Meal time should be pleasant. Use different categories of food, sprouted, malted, to adopt eating habits developmentally appropriate. Indications for admissions are when patient is not responding. Prognosis, maximal brain growth occurs during fetal life and first 6 to 12 months of age, and therefore early recognition and has to be given. Otherwise, they have got a bad prognosis in future. Ideal catch-up rate starts by 2 weeks to 6 to 9 months. Head circumference catches up first, then the weight and then the height. Or while recovery, weight is the first to start catching up. Rapid catch-up weight in IUGR, it can lead to lifestyle diseases in IUGR babies, and refeeding and nutritional recovery syndrome can occur over a short period of time. Thin and short parents, they are less likely to have a basketball player. Prognosis for organic failure to thrive is variable and depends on etiology. Prevention is better than cure, and pick up the bus early. Achieve harmony in thoughts with mother, relatives and obstetricians as well. Optimum diet control of obstetrical conditions during ANC is important. Kangaroo care, exclusive breastfeeding, weaning timing, and quality of food of utmost importance. Early treatment of treatable conditions, support, stimulation, and education. Message is that failure to thrive is a common, unnoticed undernutrition in a busy practice. Failure to thrive during fetal life and infancy can lead to significant persistent neurocognitive retardation. Feeding infants and children is a challenge. Food refusal is common. Hunger strikes. And to cajole, bully, or bribe or batter is no answer. Should not turn meal times into a battlefield and war between generations. No single right way to nurture a child. Anthropometry, growth charts, clinical evaluation helps in diagnosis. Early detection and counseling helps in restoring the growth deficit. Realistic goals should be aimed while planning the dietary therapy and should be communicated to the mother. Time, test, and treatment, it all matters about the prognosis. Education, encouragement, patience, reassurance, and homely psychotherapy is all that is needed in supporting the family child. Thank you very much. The greatness which does not bow before children is wonder if we do not bother about the child's nutrition. What Khalil Gibran has said. Thank you very much for patient hearing and giving me a chance to speak and communicate to you about failure to thrive in children below 5 years of age. Thank you very much once again.
Sir, extremely thankful to you for accepting our invite on behalf of Maharashtra IP, Dr. President Dr. Ram Gopal and Secretary Dr. Amol and the entire Maharashtra IP team.
Thank you, sir. Welcome.
Sir, it was a very comprehensive and lucid talk. You touched upon each and every aspect of the faltering of the growth. You have elaborated the pattern of growth faltering, and there is no alternative for using the growth chart in your OPD practice. The growth chart has to be used. Whatever you are using, follow them, but please use it. Complete clinical examination and a complete dietary history, the social history are at most important. And we all know that after the birth, the first 2 year, the brain has got its maximum growth. So any insult to the growth in the first 2 year of life will have a lot of long-term neurocognitive issues like ASDs, dyslexias, and so on and so forth. So don't miss the window of opportunity, which is the first 2 year, with the proper dietary advice of
including
breastfeeding
even the
and
fetal
weaning.
life. The parents,
Yes, and
the
also let's
obstetricians
start with
has
the
to
fetal
be,
life.
yes,
Yes, sir. So there must be some queries from the virtual attendees,
right,
but we will take it at the end.
right, right. Okay.
Now we have another Star Wars who is the master in the field of uh, pediatric infectious diseases. He is none other than Dr. Pramod Kulkarni from Pune, consultant pediatrician, attached to various institutes. Lot of achievements and awards in his professional and academic career. He has trained in pediatric infectious diseases from UK. He is the executive board member of Central IP and a very popular teacher and a very dedicated academician par excellence. So we all know, friend, infection is a bread and butter for the pediatrician. The most common condition for which the child comes to you is infection. So the challenges in today's office practice is how to recognize the pattern of infection which are changing. There are a lot of changes in the clinical course of the or the natural history of the infective diseases. We have new bugs, we have re-emerging infections which were there in the past, and so a good approach in the office practice itself uh, can localize to the etiology of the infective process and can recognize the pattern of the illness. So over to you, Pramod sir. So make it full screen. Your screen is visible. Make it full screen.
Sir, unmute.
अनम्यूट करा सर आणि फुल
Oh.
स्क्रीन करा. प्रेझेंटेशन मोड मध्ये करा सर.
उसका अपना नहीं है.
Slide show.
हाँ स्लाइड शो कर.
Sir, slideshow ला from beginning.
Oh.
हाँ ले.
Yes, sir.
Yes sir. It is there.
Everybody, thank you very much, Maha-IAP, Dr. Ram Gopal Chezara, President, Dr. Amol Pawar, Secretary, all the team Maha-IAP 2024, and my dear friend, Dr. Sanjeev, who is moderator today, and all my friends. At the outset, apologies for little weak voice, which you are not used to from my side.
Sir, the special mention that Pramod sir was not keeping well, but I requested him to join. So thank you, Pramod sir. In spite of your bad health, you have accepted our invite.
Sanjay,
Thank you,
it's
sir.
my pleasure to be here, and the apologies at the outset for the deficiencies on grounds of my unwell health, and again the content. So here today, as the topic says about, or the focus of this program every time meant for office practice tips, I firmly believe in and practice minimum number of slides. And a gentle request, humble request to attend what I say. First disclaimer to say that to call myself master in PID is too adventurous. I have practiced at a small place, Mofussil place, where no other pediatrician was available over 30 years. And uh, since 1990 onwards, until last 5 to 10 years, infections were bread and butter and are still the bread and butter in the peripheral part of Maharashtra. Not the same, but to some extent in urban area also, where I am practicing over last 7 years now, the situation is not different, but a major chunk is normal baby visits as well and immunization. But both are necessary for our practice and for mastering the infections. So let us look at some of the tips which come to my mind. So looking at the topic itself, what is mastering? I just asked. And what the dictionary says, mastering is to learn to do something well and to control something well. We have to do mastering the pediatric infections, means a good control as well as management and everything of pediatric infections of childhood, that is 0 to 18 years of age. For sake of convenience, we will omit here the neonatal age group. Infections, you know very well, viral, bacterial, fungal, parasitic. We have learned, we have focused more towards bacterial for the exam, then for the fungal and parasitic as well, and viral, which is the biggest foe or the biggest friend, let us call it, biggest companion in our practice. We have not learned much about it. And whatever we have learned is by practice and by the acquired knowledge in the practice from our peers and the available resources, whatever come our way. In a solo practice is very important. In office practice, infection, you know what type of infections come to you. So the first approach in any possible infectious illness in solo practice, the first priority is not diagnosing the infection itself, not managing. The thing is assessment of the seriousness as we go by the ABCDE approach of the PALS, pediatric advanced life support. So assessment of a child depending on the physiology and the vitals deviations, interpreting and what the child currently wants support and management and treatment in form of possibly antibiotic the child needs immediately. This is the first step to any problem or any patient coming to NOPD, and infections are no exception to it. So after triaging the child into a stable, likely to be unstable or high risk, or destabilized, depending on these three, will approach next management approach. So about the child who is likely to destabilize or is not unstable on few of the parameters or is high risk, we are definitely going to advise hospitalization, little proactive in investigations as well as monitoring of this child for timely management of the possible infection. About an unstable child or destabilized child, as in frank septic shock, we are not going to wait and transfer this child immediately to a relevant unit or relevant nearest setup, maybe critical care or high dependency setup or a specialty care setup where we can have it. So after this initial triaging, what we are going to look at, the second step would be the infection approach to infection. After triaging, we are going to diagnose the infection. How do we diagnose the infection? Basically, I will insist on, again, as said by Dr. Ambedkar and all the great clinicians and masters of pediatrics in this country, the clinical diagnosis is reached in 85% of the cases. What I am saying is an evidence-based statement, is only by a meticulous, characterized, well-characterized, meticulous history, which takes not more than 8 to 10 minutes. An additional 10% coming to 95% of accuracy by a short, brief, but focused physical examination. 5 minutes general examination and 5 minutes relevant systemic examination. And another 2 to 3 minutes to recap, to bridge the gaps in our diagnosis, and you reach the diagnosis, provisional diagnosis. I will request you to, Dr. Ambedkar always says, put your diagnosis on your prescription, on your notes. What I will ask you, if you cannot put the diagnosis, precise diagnosis, nobody can. It's a rare occasion you can clearly diagnose the infection by just appearance or few of the clinical findings. That is not a common scenario. But many a times the things are not very clear, especially these days when the newer viral infections are coming. The older viral infections are behaving unusually. The bacterial infection behavior is changing. The antibiotic usage had changed all the natural courses of the infection. In this case, it's better to put your diagnosis as clinical infectious syndrome. To say like that, as we have been clearly told about in the ID modules of IAP, like APID or ULTRA or PSPID, the clinical infectious syndrome, like URI, LRTI, pneumonia, or complicated pneumonia like this. Then intracranial infection, meningitis, meningoencephalitis, and encephalitis and others. Then you have skin and soft tissue infection, superficial, deep, mild, and severe, uncomplicated, and complicated. Give these adjectives. Then the enteric infections, enteric infection, gastrointestinal infection. Amongst that, diarrheal illnesses, number 1. Number 2, gastroenteritis. Number 3, enteric fever-like illness, fever of short duration, less than 5 to 7 days, which we typically get in our office practice, where the DD can be huge range between your commonest these days, dengue fever, can be any viral infection, can be sometimes enteric fever, and can be rarely in Maharashtra, in particular areas or other areas of India, malaria as well. Depending on seasons, you have to entertain the less common infection as well, which are seasonal, like the leptospira in the month of monsoon, especially when the water wading occurs. And secondly, the rickettsia, which occurs later at the harvest time, sometimes after the September. So these are 2 additional infectious illnesses we need to know. Then you have to know about the musculoskeletal infections as well. So these are less common, but septic arthritis, osteomyelitis, or a combination of both. Okay. The infected endocarditis, then the sepsis, all these bloodstream serious infections are less common. URI we further divide into, know very well, otitis media, nasopharyngitis, tonsillopharyngitis, and the other associated common respiratory clinical syndrome. So putting the diagnosis, and rarely apart from these office infection, become across occasionally fever more than 1 week, which can really deserve to be called as PO after initial evaluation. So that's a little uncommon scenario. So my request, first clinical diagnosis, put your provisional infection diagnosis as clinical infectious syndrome, as I told you. It will precisely localize, narrow down the possibilities. Next, further differentiating a possibility of viral and bacterial. We are masters of that. You know very well, viral to start with, it is the fever is high. The symptoms are maximum at the they correlate with the viremia, and at outset they are the highest, which gradually decrease over time in a standard case. In bacteria, to start with, it is low and it builds over first 3 to 4 days. So change in behavior of a fever around 3 to 4 days is one thing. Then number of organs in one system involved and number of systems involved, more in favor of viral. Of course, this is generalization. Thirdly, the epidemiology, we know it very well. What is happening at home, in the community, and in the country, in the region, we must know very well the epidemiology. Current epidemiology is one of the way of narrowing down the pre-test probability of your lab diagnosis. So putting down the diagnosis clinically is the finest way of being. Your clinical examination will further make it down. Put the adjectives as I suggested, so that it will tell you what is to be done. Okay, this is about the clinical diagnosis. And about the diagnosis, laboratory diagnosis. Okay, about the laboratory diagnosis, let me tell you the basic sub-tips for diagnosis. So what are these? Understand your test, get convinced and counsel with conviction about need and cost effectiveness of the test you suggest. Know about the test, right time, right site, right specimen, right volume, right collection, right storage, right transport, right laboratory, and right interpretation of the result. All are very, very, very important. And unless you are convinced about the test, let me tell you my only take-home message from my peripheral practice. If you want to rule out meningitis or rule in meningitis, CSF cannot be obviated. CSF is a must. Unless you are convinced with this, you cannot convince your patients. The first hurdle everybody has in our practice. In neonatal sepsis, again the same thing. Culture in typhoid and serious infection, bloodstream infection, neonatal infections. In solo practice, if you are dealing with them, blood cultures and the CSF and the relevant other cultures, UTI, urine culture, all these are mandatory. Unless we do these, we are in no position to treat these conditions properly, rationally at all. Treat with what, how long, what test to repeat, which agents to, when to change, whether to de-escalate, whether to escalate, depending on the response. Everything is in the dark. So get the diagnostic gold standard, the best one. Nowadays, we can't have any excuse of non-availability of tests. Almost every village, or let us say town place, has a laboratory, or a person carrying specimen daily from the peripheral place to central laboratory at district place within few hours time. I practiced it for 15 years from place like Bor, which is 50 kilometers away from Pune. I was sending cultures 10 years ago. So it is very easily doable for everybody. The labs will welcome your offer and they will send people every day in the morning to collect the sample. So collect your culture sample, store them well, hand it over to the people. Just arrange the scheduling of your test, collections and storage. And you will get the report on the your mobile also by evening, the earliest possible report. So you can make your specific treatment very rational. This is my first message. And don't worry about the cost. Let me tell you, cost of, as we say in vaccines, you always convince your patients about typhoid vaccine, don't you? 2,000 rupees of typhoid vaccine cost is cost effective, because typhoid illness takes 1 week to suspect, 1 week to diagnose, 1 week to treat, and 2 weeks to recover. And it consumes almost 50,000, at least 50,000 rupees in private at a semi-urban set. So to save that, you will always spend 2,000 rupees to avoid 50,000 and discomfort and morbidity of child and all the concerns of your mind. Similarly, about important diagnostic tests like culture, especially CSF and blood, you should always insist this is going to help us to decide proper decisions to be taken and to be continued everything. The duration of treatment is changing these days. We'll come to that. About the other tests, so microbiological and direct diagnostic tests are only reliable for diagnosis and for medical legal purposes. Let me tell you very frankly, your Vidal is not going to stand with evidence even in the court of law. A positive Vidal is not typhoid fever essentially. Vidal test is obsolete. So similarly, what we have to do is blood culture. So that is the way, my way of telling you how it is important. So direct microbiological tests are only reliable, like cultures from body sites, sterile or unsterile after proper interpretation and lab procedures. Microscopy, stains, PCR. Let me tell you something about people always grumble about the cost of PCR and the short, let us say, the available sets available. So influenza RSV sets are available in Pune. They can be made available. Ask your laboratory to make short batches of PCR together so that can serve your purpose. So you have influenza, you have RSV, COVID is no more there. So if you have these two, that is good enough. So if you need something more, then the biofire comes in. But your labs can always arrange a standalone or a combo rapid PCR test, which is absolutely cost effective in most of the viral infections. You must have realized in adenovirus epidemic we had last year, and it is going to be useful. You just cannot shy away from the buzz of the time and need of the time. PCR are going to replace everything. They are going to be very friendly to all of us in next few years. And you have started realizing the beauty of diagnosis since COVID era and last 2 years again. And the antigen tests sometimes, but they are not. NS1 is the example of antigen test, which is highly reliable for dengue diagnosis. Let me bring back your attention to indirect tests, which are not at all. Even if I have not written, let me say not at all reliable, which are host responses. You cannot bank on, pat your back, diagnosing some infection with CBC, inflammatory markers, ESR, CRP, Procal, or antibody titer based tests, any of the tests, except rare situation of the viral infections or fastidious bacterial infection, where you don't have that good direct test available, which is a rarity again, or unusual infection. But this is not a common OPD scenario. This is my message or tips for you for mastering the diagnosis. Mastering the management. Mastering the management is giving the necessary support, specific support immediately. Number two, specific antibiotic treatment when needed. When needed. Most of the OP infections do not need antibiotic. Most of my friends, seniors, those who are actually practicing rational antibiotic practice will agree with me, will send a figure of 5% a rational need of antibiotics in office prescription practice. 5% or less than that. That is the genuine one. And you can also try and you will convince yourself, you will realize 95% of the times it is not needed. The antibiotic has to be single, site effective, narrow spectrum, has to be safe, very, very important, has to be safe, is a priority in office practice. You just can't go ahead with the odd fancy antibiotics who have got uncommon but very serious side effects, okay? And only when needed, as I said it. Again, with the due test done, due specific microbiological test done, and clinical monitoring of the child on OPD basis with the red flags and appropriate follow-up, shortest duration of the antibiotic therapy is suggested. Do you know current trend of world antimicrobial recommendation, duration recommendation? It's coming down, down, down on all the sides. Pneumonia can be rationally evidence-based treated with only 3 days of antibiotic. Next year, we'll be having that recommendation. Meningitis, pneumococcal can be treated in 7 to 10 days of IV antibiotic when susceptible. Similarly, osteoarticular infection previously treated for months together can be treated with parenteral antibiotics of 2 weeks only or lesser than that with oral switch. So there are many, many things and changes happening in all the infections, the duration of treatment, and we have to adapt to it. So shortest duration is very important. Monitoring for adverse drug reaction. Never ever ignore the child family coming to you with suggested possible side effects. On the contrary, you proactively tell them anticipatory guidance. When you are prescribing co-amoxiclav, tell them this might give the child some loose stools, but please don't worry. Carry on with oral rehydration therapy. And if you feel it is not helping, see me, and then we'll decide about stopping the antibiotic. Usually, as a consensus, 4 to 5 antibiotics suffice in pediatric OPD, average pediatric OPD at all the setups. For skin and soft tissue infection, cephalaxin or cefadroxil. For below diaphragm infection, like common being UTI and enteric fever, cefixime. Respiratory infection, significant upper respiratory infection, like otitis media with diagnostic criteria, and possibly group B, group A streptococcal pharyngitis or bacterial tonsillopharyngitis or sinusitis rarely. In these cases, amoxicillin is usually sufficient in 45 milligram per kg per day dose of proper duration for individual condition. Amoxiclav, reserve it as second line. It's the broad spectrum. Please don't use it as first line. It has to be reserved for resistant or beta-lactamase producing organisms, that is NTHI or Moraxella possibility with refractory non-responding respiratory infection. It's not needed in pneumonia. And admitted patients, let me tell you, ceftriaxone is the only antibiotic which I will recommend you to restrict for in solo practice, irrespective of your setup. So that is the message about management of antibiotic. The essential one, referral. Monitor the child clinically well. For that, you have to need the course of disease, whatever your provisional diagnosis is, and the final diagnosis is after the investigations. If you have done investigation, you have to selectively do the investigation when necessary, when the infection is significant. So for common pneumonia, you don't need investigation. Gastroenteritis, you don't need investigation. Enteric fever, you do need investigation. Otitis media, you don't need investigation. Tonsillopharyngitis, you don't need investigation. So SSTI, you don't need investigation. Complicated SSTI, you do need investigation. Pyogenic infection, abscesses, you do need investigation in larger or complicated infections. Okay, in complicated pneumonia, you do need investigation. These selective investigations, and above that, clinical monitoring, knowing the course of disease, what is remission, what is response, and lack of it, read it properly in time. If within given frame of a standard behavior of a disease, if there is no response, review your case. Don't change the antibiotic. Take a second opinion. Maybe your own colleague from your smaller place or your close one from a bigger place also can be of your help. Second opinion costs very little money but serves huge purpose. And respect that second opinion. Respect that second opinion. Take call, consensus call of at least 2 people and decide about the further action. This is about management. And mastering prevention. Immunization. I did not say anything about immunization. We are already well learned about the immunization. We are updated about the immunizations. We are proactive in suggesting, recommending, and doing the immunizations. So little less in periphery, but the awareness is increasing, and we have to take this message in periphery as well. We know the changing trend of practices across all the country, across all the setups, and immunization, we are going to lose this as our source of revenue in next few years. We have to accept and admit that, still be on with proactive immunization, promotion, and administration. Wash. Let me not say about it. How many of us tell gastroenteritis patient to buy a soap, which my teacher used to ask first question in examination and during rounds, to show a soap from the family by the sides of on the counter of a patient of gastroenteritis, of a patient of enteric fever? Do we do it routinely? Similarly, after the COVID pandemic, we have forgotten about the respiratory exposures. We are not using a mask. We are not using hand sanitization. We did it so well for 2 years, and now we have forgotten about it. How many of we are still continuing use of AHD or alcohol-based hand sanitizer or disinfectant after and before each patient in our OPD practice. If it is so, you will need one bottle of 500 ml AHD per week, with average OPD of 20 patients in your OPD. Okay, so look at your consumption of AHD. If it is less than that, you're not using it. Use it before and after each and every patient in your OPD. Water, sanitation, and hygiene. Be proactive about it. And other infection control practices. RSV, measles.
Sir, last minute.
RSV, measles, influenza, parainfluenza, varicella, we have all the adeno, all the fancy respiratory infection. Use of your mask and contact prevention or close contact prevention is very, very, very important. Don't forget that. Close contact avoidance. And sometimes isolation of a patient, as in case of pertussis, is also equally important, sometimes in tuberculosis also. So these are all the tips of mastering the prevention. This is what I have in my basket today, just to tell you on extempore. These are my tips for all you practicing in office practice. This is the only way I have mastered management of infections in solo practice. That is all from my side. Thank you very much. Thank you very much, Mahaepi. Thank you very much, Sanju Bhai.
First of all, thanks a lot, sir. In spite of your bad health, the vigor and the enthusiasm was same as we always witness you. So extremely thankful to both the esteemed faculties. Would like to sum up Pramod sir's talk that your approach in the office for a suspected infection requires a good comprehensive history and a short but complete clinical examination. Your first aim should be to recognize the seriousness of the illness so that you can prioritize the management. You can prioritize which child needs hospitalization or not, and which child will need antibiotic or which child will not be needing antibiotic. You must recognize clinically infectious syndromes like we have in neurology, acute encephalitic syndrome, then the shock tissue skin infections then upper respiratory, lower respiratory enteric infection, then UTI, because that is narrow down your etiology and will help in the management of the patient. Always consider the local epidemiology, because it is very utmost important to know what is prevailing in your area, what infections are going on. Then you must know the clinical course, the clinical pattern of the illness. Like in a child with dengue, if at all you know the pattern of the illness, you can very well on day one or day two only can uh, pick up the patient, those who are with the warning sign, those who are not with the warning sign, and you can very well follow up that child. And most important is the judicious use of laboratory. 2 days history of fever without any focus in a child above the age of 6 months does not require any urgent use of laboratory. You can always wait for few hours, or you can always follow up that child. And judicious use of antibiotics. Friends, antibiotics are the poorest antipyretic in the world. So keep them reserved for those patients only, those who need them. Rambhai, any questions are there in the chat box, or you want to sum up?
One person has asked Dr. Pogragade sir, what about adding salt and jaggery in the feed?
Pogragade sir, unmute kara.
Am I audible?
Yes, sir.
Yes, you asked about the importance of sugar and jaggery in the child of a weaning child, okay?
Yes,
in the first, say, 1 to 5 years of age. Yes. that can definitely have two important aspects. One is that jaggery will add some iron to the child's diet, and therefore will have preventive aspect of the development of anemia. And deficient anemia is very rampant in India as well as in many developing countries. So use of jaggery is very much important for prevention of iron deficient anemia. Number one. Number two, it adds to the taste of a vegetables. Green vegetables as such, many times the child doesn't want to take it. If you add a little bit jaggery to it, it will definitely increase the taste of that particular foodstuff and will improve the intake of these particular vegetables. That is important thing. About the sugar, we all know that the breastfeed contains the one cup of milk, that means 200 ml, will contain almost 3 teaspoonful of lactose. That means there is a significant amount of sugar which is added by the nature to the child's diet during first half of the infancy. Now, this particular child definitely wants that the whatever the next feed he is going to come after, say, weaning period after 6 months of age, he want the similar tasty food, and therefore some amount of sugar addition in the, say, top feed or in the whatever the food the child is taking, that will add to the taste and child will start taking it very lovely. The concept that sugar equivalent to worm infestation, that is more of a myth than a reality, and therefore that should be taken out. Unless there is a risk of any obesity, sugar is not to be forbidden in a child's diet. This is what is my personal feeling. Though Western people say that sugar should not be added, but the some amount of sugar will not create any nuisance to the child's nutrition.
Thank you, sir. Your point is well taken.
Dr. Anil Diwan has
I think
raised hand.
Dr. Anil Diwan has raised his hand.
Yes,
Kobragare
Anil.
sir, namaskar.
Namaskar, namaskar, namaskar. Glad to see you on this webinar.
Thank you,
Right,
sir.
right.
The use of milk as weaning food is important in failure to thrive cases.
Use of milk and
Milk as a weaning food early. That will mean loss of appetite, anemia, and many children will not use or take this solid food. They
no
continue with milk.
ideal situation is that the breastfeeding should be continued. Along with that, semi-solid food is to be added during the weaning period from, say, at least 4 to 6 months of age, and then gradually the solids are to be increased rather than the liquid diet. The amount of milk the child can tolerate may be that up to, so what Western people have recommended is 0.5 to 0.75 liters per day. This is what is the recommendation. That takes care of proteins, that takes care of calcium, and many of the nutrients which are present in this milk itself. Only disadvantage, the greatest disadvantage, is that it doesn't contain iron, it doesn't contain fluoride, and therefore these are the two things which, and the vitamin D also is not there, and therefore this is the one thing which has to be taken into account when you are giving at all the milk-based diet. But amount of milk should be reduced gradually over a period of time. Excess of milk unfortified with sugar is found to have more amount of constipation, and therefore the solids or the weaning food are also not taken in adequate amount.
Thank you, sir. Thank you.
Thank you, sir.
The
Thank you.
last question is from Dr. Minaj Sheikh. Then I will ask one
Nee.
question to Pramod sir, and then Ram Gopal sir.
No, no, there is one
go ahead.
announcement. Sir, somebody has asked to show the slides again. They could not, they have not seen. So for them, the session, it would be available on the YouTube immediately once we finish. So you can go onto the YouTube and you can see the session again.
Yes, yes. So Minaj, whatever questions you have, Minaj Sheikh. Yeah.
Good evening.
Minaz.
Good
Good
evening.
evening, good evening, good evening. Nice to see you on this webinar.
Thank you, sir.
It's my pleasure to see you.
Dr. Minas, there is some issue with your voice.
हाँ,
You are not audible.
क्या पूछना है भाई पूछ हाँ पूछना
आवाज नहीं आ रही.
Okay.
हाँ.
Sorry. Now it is coming.
Yeah.
Yes.
Now it is coming.
Yes.
Yes.
Sorry, my apology.
You are visible.
As usual, it has been pleasure to listen to Kobragare sir and Pramod sir also. I have one query or my reservations about Pramod Kulkarni sir about that particular saying that it is clinical infectious syndrome. I mean, when we say syndrome, it's a constellation and combination of symptoms and sign, and one may not be getting all together at one go. So we can say about that, but is it okay we simply say it is acute febrile illness and we go from there onwards? Pramod sir.
It's just a starting point. That is the only, it's a suggestion to start. Okay. And that is what you have to start with. At the end of your clinical examination, after history and clinical examination, you know what system is involved. Okay. That is going to, so the clinical infectious syndrome I said about. So clinical infectious syndrome, as you know, the system wise, SSTI, URTI, LRTI, enteric infections, UTI, intracranial infection, this becomes a syndrome, systemic syndrome. And you put adjectives, what it is precisely. Once you come with this, there are very few conditions under that. So meningitis, encephalitis, meningoencephalitis are the three commonest ones. That is to be put, and you narrow down your diagnostic approach and therapeutic approach with the syndrome as your reference for your antibiotic treatment. So if you are next, it has to be put on with AOM, complicated, uncomplicated, high risk or no risk. Okay, routine risk or high risk. Like this. Tonsilopharyngitis, mostly bacterial. So this is the approach. You put it syndromic diagnosis. The precise diagnosis is a microbiological diagnosis, which is very, very unusual to keep clinically. So syndrome, clinical infectious syndrome, I said. So acute impetigo, acute cellulitis, acute necrotizing fasciitis are the clinical syndromes.
Excuse me for my comment on this particular issue.
Yes.
That the child has got a febrile illness. This febrile illness could be either infective or non-infective. We really do not know. And therefore, the title of acute febrile illness, whatever may be the cause, that stands better than calling it as a infectious, unless you have got a clinical particular, suppose evidence that particular child definitely has got evidence of infection, then only we can say that it is acute infectious illness. But if it is not there, it is better to call it as acute febrile illness, and our options are open for investigation as well as management. This is what is my personal feeling.
Basically, in the infectious syndrome, we have already learned about the febrile syndrome, which is short duration fever, long duration fever, prolonged fever, or PEO, like that short duration fever, which is the commonest OPD practice problem, is fever without localizing sign, fever without focus, or with focus. That is how we go. It is again an infectious syndrome. So fever without focus can be infection, can be non-infection.
Non-infection. That is what is
exactly. So that is the reason, sir. We are inclined towards writing as acute febrile illness, fever without focus.
Acute febrile illness, you can say acute short duration fever. That again becomes a syndrome.
Sir, one important comment about Vidal. See, on the IIP platform also, we are advocating against the use of Vidal for the diagnosis of enteric fever. But let me tell you honestly, it is the only test at the most peripheral places in the country, not only Maharashtra, but entire country. And if at all you have a situation that the 1 week fever has the fever is more than 1 week. Already the child has received antibiotic, and to tell you the ground reality, there are no facilities for doing a culture test, which may not be positive if in our country a child with fever for 1 week and without antibiotic is a rarity in the actual
Specifically
scenario.
rural setting.
So if at all the child has passed 1 week of fever without any obvious focus or some gastrointestinal symptoms, some respiratory symptoms, not amounting to that particular system, and if at all the practicing pediatrician wants to do a Vidal test at this particular time, at the right time, as you already told, the right time, the right sample and all, will it be judicious to use or interpret to use Vidal in that particular scenario?
I fully agree with your sentiments, Sanjeev bhai. But we again the circle comes back to the same thing. I practice whatever I say. I have not sent Vidal test for more than 10 years now. Not a single prescription of Vidal test. I never look at the Vidal test reports in referred patient. I keep it totally aside. And the scenario, see, the common excuse given by all of us, basically to tell you it is an indirect antibody host response related test, which is just a toss of coin, you can get anything. It is not reliable in pre-treated patient or untreated patient. It has hardly any value. Blood culture, to tell you, has got good positivity even in the second week. Even after antibiotic treatment, it scores way above your Vidal test. And once we stick to the positive Vidal test, it's a big problem. I regularly see many patients turning out to be something ghastly. Many leukemias, rheumatological disorders, brucellosis, tuberculosis labeled as enteric fever based on Vidal test, and the things are very problematic. Please don't do. Being at periphery is no problem at all, sir. You can keep the blood culture tube in room temperature up to 8 hours also. So to the transport time, you can send the relative to the district place or nearest possible good culture laboratory with automated systems with the bulb what you have taken. Send the person with the bulb to the laboratory, which is anytime cost effective then. Because if it is positive, it is 100% culture proven typhoid fever. If it is not enteric fever. No Vidal doing at any cost. And I am not going to indulge into interpretation of Vidal test done anytime, anyway. No respects at all.
So very bold statement from Pramod sir that say big no to Vidal. And those most of the patients are, see, I am also practicing at a peripheral place only. So most of my patient comes from the rural area and they come with the so-called their local laboratories. Those are not even qualified pathologists. Those are all run by the so-called what you call quacks, the
DMLT
DMLTs and
technicians.
all, and they come with just 2 days fever, 1 day fever, and strongly positive Vidal. And the practicing GP or the pediatrician at the periphery has already convinced the relative that your patient is suffering from winter fever, uska Vidal test positive hai. So this is say big no. So you communicate to the parent that this is not a test to be done at all, or if at all has to be done after the end of 1 week. If at all you have to say that this is a judicious test, say big no to any report of Vidal which comes to you in 1 day, 2 days, 3 days. And according to Pramod sir, there is no role of Vidal as such in the diagnosis of enteric fever. So I think we are.
One small comment can I have?
Yes.
Sanjay bhai, one-liner from my side.
Yeah.
3 days fever without focus, stable child, no investigations. No investigations. A young baby less than 2 years fever without focus, urine can only be justified. Urine routine with dipstick and as needed culture. Day 3 CBC urine NS1 CRP. That's all. And day 5, if there is fever without focus, don't forget to send blood culture. Day 5. Don't make it beyond 7 days. Day 5, if the child has fever without focus, send blood culture on day 5 itself.
So very nice to see Bhavesh bhai, our scientific coordinator. Are unmute karo bhai.
Sanjeev sir, Kobragade sir wants to come in. Kobragade wants to say something.
In a evidence-based scenario, naturally, typhoid fever is diagnosed only by blood culture. Everybody knows about it. The only thing is that the parents' expectations are altogether different. They already come with antibiotics taken for a couple of days, and even after doing blood culture, my blood culture 80% of the times they come negative, and therefore we are in a fox what to do. And therefore, alternative methods, either by clinical judgment or by other tests, one has to find out whether it is really a enteric fever or not. Moreover, the parents' expectation is that the patient must be cured within few days, that, and they don't want any more time to be taken up. So that is the reason. So we are sandwiched between.
Sir गए. Sir got disconnected. नहीं, Kulkarni sir, there is one more terminology used by the GPs or pediatricians also at periphery. Once the patient comes with the Vidal positive O and H, they say it is a double typhoid.
What shall I
Have
say?
you heard the terminology of double typhoid?
No, no.
Sir, what is this double typhoid? It is there, Rambhai, it is there.
Yes, so I want to know what is double typhoid.
Paratyphoid positive as well as S-type positive.
Yes.
Could be double paratyphoid, which is a rarity. Which is a rarity.
There is another term, typhoid ulatla.
That's true. That is true. It's a relapse. What they
So
say.
a big takeaway from Pramod sir, when you have a situation of fever without focus, less than 5 days, the only laboratory investigation is CBC, NS1 if the epidemiology is favoring a dengue diagnosis, and a blood culture and urine examination, routine urine examination. That is all.
Bhavesh.
And even though Bhavesh sir, आपकी कुछ
Yes.
There are few
विशेष
there are few
comments?
more questions. There are few more questions on the chat that people are asking. What is about the typhoid.IgM? I think it is
Bogus
very
test.
clearly told by Dr.
Bogus.
Kulkarni sir and everyone that these are totally unreliable tests.
100.
And in one of the scientific fora, it was a very blunt and bold comment by one of the very senior pathologists saying that if you really need to do a Vidal test, instead of spending few $100, you just a 5 rupee coin, you toss it. If it is positive or negative, it will give the same information the way you will ask for a Vidal test, because based on the Vidal test, you will not be able to define whether it's an enteric fever or no. So I think it's a more of a clinical judgment. Presence and availability of the blood culture is the gold standard. If it is not so, I think the clinical judgment is more important than relying blindly on the typhoid.IgM or Vidal test.
So say big no to those so-called anti-typhoid dot and all those tests. They're really. So
Absolutely.
I think I request Ram Gopal sir to conclude.
Sir, you can conclude
Only
and
11 बज रहे.
vote of thanks. Yes, sir, you can do that. No problem.
अच्छा.
Joshi sir, you continue.
अच्छा. So thanks a lot, both our esteemed faculties, respected Dr. Khobrakade sir and respected Dr. Pramod sir. You have done full justice to the topic. One of the most common two clinical scenarios, very important for the office practice. Thank you, Bhavesh bhai, for your presence. Thank you, Minaz. Thank you, all other office bearers, EBs of Maharashtra, IAP, and most important, our virtual attendees, our honorable members from Maharashtra IAP. You were there in a very large number, and your presence is the only thing which is encouraging us for bringing these stalwarts on this virtual platform. So again, a big thanks from Maharashtra IAP to each and every attendee on this virtual platform. So good night. Thank you all.
Good night. Thank you.
Thank you very much.